Such a strange histogram for a case of a uterine septum. You can obviously see multiple filling defects in each cornea. They're very regular, so this indicates a multiple endometrial polyps. So the challenge is to do hysteroscopy for septum surgery while the cavity is full of polyps like this one. So please join me to enter the cavity, and I want to repeat again that all these series of videos are live from the operating room, no editing, and no any adjustment is done. So we live together the challenges, the frustration. During vaginoscopy, there is like a reddish spot in the posterior fornix. It could be simply an adenosis, and use the fluid pressure to dilate the external os. So open sesame like this. So in the vaginoscopy technique, there is no speculum, no teneculum. You depend on the pressure of water to enter the cavity. And then slowly enjoy the view of the endocervix. You have continuously to readjust the focus and stop at the level of the internal os. Don't go quickly. Please, please, every word I say had a big meaning. Give it a time at the level of the internal os, then rotate the telescope and go. The posing at the level of the internal os give a chance for the fluid to go first, distend the cavity, so you avoid to enter in a collapsed cavity and you hit the tissues. If you do any friction or scratches to this endometrium, believe me, surgery will be a hell. There is a lot of floating tissues. You cannot be able to identify the septum, and you might go in the wrong direction, and you will not have any identifiable landmark like this point. Tubal ostium, this is your GPS landmark. So both tubal ostia are your landmark to design the level of cutting and when to stop. Let's now see some of the frustration. When you go into the cavity and you find some blood and clots like this, what to do? The resectoscope sheaths have the inflow channel in front at the level of the tip of the lens and the outflow a little bit back. So you have to push the resectoscope a little bit inside to allow for the drainage, then rotate, align your knife perpendicular to the septum, look up, look down, exactly in the middle. And when I say in the middle, that middle level is not the same as you go up. Again, at the start, this is the level of cutting in the middle. When you go up, you have to readjust your knife few millimeter up and down because the uterus is antiverted, okay? Move the electrode from one side to other side. I'm not happy with this blood clot on the left cornea because it hides the tubal ostium. I give you a golden secret advice. Okay. I'm cutting from side to side. I want to get rid of this blood clot. Here comes the value of live surgery. So push your resectoscope near the cornea so the fluid will hit to the fundus and make a turbulence coming back and push this blood clot outside. So as you see, no need to go outside totally by the resectoscope. I will repeat it again. If you have one cornea full of blood or clots, so gradually and slowly guide your resectoscope sheath to come very close to the cornea, very close to the fundus of the cornea, and then the jet of water will make a turbulence, pushing the blood clot to come behind your back and expelled from the external os. So now we continue back the procedure of, what is this? There's a lot of vascularity, and what you see is a muscle tissue. Okay, the septum is muscular or fibromuscular with more predominantly muscular component. We did a research about the effect of muscular components in the septum on the reproductive outcome. Septum with more muscle component has more chance for recurrent pregnancy loss and reproductive failure. So what you see in these spaces spaces between the fibers of the septum retracting is muscle fibers. These are muscular fibers. Usually the far lateral edges of the septum are more fibrous than the central part, which is more muscular and vascular. Now I'm looking at my GPS point, which is the tubal ostium, to know when to stop. The final cut-off limit when both tubal ostia are at the same line. Now we come to the more secret tips. Fluid pressure is needed to distend the cavity, but it will compress on the wall of the uterus and flatten the thickness of the myometrium. So when I decrease the fluid pressure, you can see the bleeding vessels and you can cauterize. So during septum surgery, the more you climb up toward the fundus, please decrease the fluid pressure less and less. So I start the surgery with the higher fluid pressure, and there is no number to say, it depends on the size of the cavity. And the more you climb up, you decrease the pressure to avoid the pressure effect on the fundus, which make the fundus thinner, more compressed, so it can be easily perforated during resection. Here, you just touch the tissues. Look at this dark shadow at the fundus. And this movement, yes, you see that the uterus is, I don't know what to say, like in and out, because I decrease the fluid pressure like this now. I decrease the fluid pressure to see if there is any fundal falling down. Because probably with the high pressure, the fundus is pushed up and you believe that you finished complete surgery, but there is still some more to do. So my dear friends from Histopedia, this is Osama Shawki from Cairo, Egypt.